Hello.
हाँ सर.
Am I audible now?
Yes sir, yes sir.
Okay, okay.
And good evening sir. I request to each participant kindly put your camera on so that everybody will see and interactive for each and everyone. Sir, please put your camera on, sir.
Yeah, I think my camera is on.
Yeah. Your camera is on. Dr. R.N. Pandey, sir, camera is on. Now I'm requesting to other panelist member. Dr. Arun camera is on. I'm requesting each one of you, please put your camera on. Abhishek sir, please put your camera on. Dr. M.K. Jaiswal sir, Dr. Sabir sir, Dr. Manish sir, Dr. Santosh sir, please put your camera on. Shall we start the program, sir?
Yeah, I think so.
Yeah. In between, I'll be starting the program. In between, I'm requesting each participant, please put your camera on so that we take one group photographs along with all panelist member with moderator. So, good evening, sir. Myself, Sriram Singh. I welcome you all on behalf of CIPLA. Thank you for everyone to join this session. Sir, as you know very well, CIPLA has initiated a heart failure cascade for heart failure knowledge sharing for medical practitioners. Heart failure is a global burden for healthcare systems. Sir, as you know very well, aldosterone plays an important role in the pathophysiology of heart failure. All guidelines recommend the use of MRA early along with ACE inhibitors, ARB, beta blockers, and diuretics. Still in India, MRA is underutilized with only 40 to 60% heart failure patients on MRA. If you see the study of 1 year mortality is high in heart failure patients, and disease modifying drugs like MRA should be initiated timely to reduce mortality in HF patients. With this objective, CIPLA have created this platform to expert opinion meeting to percolate the awareness among all SCPs and HF cascade and role of MRA. Today we have with us a distinguished speaker, Dr. Bala Lohiya. He did DM from BHU in IMS BHU, and after that he joined BK Heart Care and doing interventional cardiologist. With this word, I would like to welcome Dr. Bala Lohiya. Please have a session and start the meeting, sir.
Yeah, thank you. I welcome all the experts today for this discussion. Welcome Dr. Arun sir, M.K. Jaiswal sir, Pandey sir, and all other esteemed all physicians. Today the topic is as all we know the importance of the heart failure. With so many patients having almost, if you see the global prevalence of the patients with heart failure, almost 10 million patients are suffering from the heart failure. And the efforts we are doing to reduce the mortality and morbidity in these patients. And so we have many medications at our hand. So our goal is to optimize the dose duration of all these medications so as to reduce the uh, readmissions and the incidence and prevalence of the heart failure among those patients. So I think I can share my slide. Uh, So, as we see, the incidence of these heart failure globally is high, as well as in India also. Almost 10 million people are suffering from the heart failure, and each year the 10 lakh people they are developing first time heart failure, and the mortality is almost 1 lakh people per year are dying due to heart failure. So the importance is with so much so high mortality, it's important to know whether we are missing patients at early stage, whether we are utilizing all the available diagnostic and prognostic tools. So I request all the panel to any suggestion or what in their practice they are seeing patient at what stage they are diagnosing, how much percentage of the patients with heart failure in this stage, like asymptomatic phase we are detecting or we are detecting at quite late stage at NYHA class 4. So I think the topic is open for discussion. Any comments from any experts? Usually, what in our cardiology practice we see maximum patient they come quite late at the class 3 or class 4. Most of the time they neglect their symptoms. It may be just like functional capacity goes down and they reduce the activity for the time. Or maybe we are labeling them as due to lung issues and we are not utilizing the laboratory markers to differentiate between whether it is actually due to COPD, asthma, or it is due to LV dysfunction. So, with so much this prevalence of the heart failure and so much research going on now, we are having main four components of the medications in the management of heart failure, like beta blockers and inhibitors, ARNI, and SGLT2 inhibitors, and these aldosterone receptor antagonists. So we need to optimize the use of this medication in supportive other things like diuretics and control of the blood pressure, sugar, depending on whether the patient is having ischemic etiology, valvular etiology, or non-ischemic etiology. So this recently in 2021, this update was there for the heart failure optimizing all the classes, and a recent update on the AGLT2 inhibitors and optimal utilization and dosing of these ARNI and aldosterone receptor antagonist. So the guidelines is specifically emphasizing on the level of potassium and kidney function before and after starting the whether we are using aldactone, aldosterone antagonist, or we are using eplerenone. So the guideline is saying we should use MRA in all patients with heart failure, whether heart the level class of evidence is class 1, when ejection fraction is less than equal or less than 40%. The patients who are having ejection fraction between 40 to 50%, which is a new classification we also call as HFMRE, of moderately reduced, mildly reduced ejection fraction, where the efficacy is class 2. So this is the overview of these patients with heart failure, where we are having the medication of ACE inhibitors or ARNI, beta blockers, MR antagonists, and SGLT2 inhibitors. Along with that, we are utilizing diuretics whenever there is pulmonary congestion or patient is having edema, the volume overload. And along with that, depending, we find out whether it is a ischemic etiology, we go ahead with the angiography, if there is a blockage, we go ahead with PTCA or a bypass. If it is a non-ischemic etiology, angiography is normal. Then we optimize the medication for 90 days with the supportive things like correction of the anemia. If there is iron deficiency, replacing it with IV injectable is better, that we are having now safer injectable ions, and if it is a valvular, then repairing or treating the wall conditions. Along with that, optimizing or adding if patient is not tolerating beta blockers, imipradine or atrazine. Uh, so my one point for discussion among all expert panel is whether how much percentage in how much percentage of patients we are using MRAs, and whether we start it along with base inhibitor or one by one. How we add on? How is the common practice? Any comment? Usually, it is seen that uh, we should start within first week. The what we follow the protocol, if there is no contraindications, at least within 24 hours, we try to start with beta blockers, AC inhibitors, or diuretics or RD. And depending, we need to monitor patient's pulse, BP, and electrolyte level. And before discharge, at the time of discharge, the patient should be on at least low dose of AC inhibitors, beta blocker, and MRA, and then should have a frequent follow, like first follow up after 5 to 7 days, and then afterwards maybe 2 weeks, and then 1 month, so as to gradually increase the doses of beta blocker, AC inhibitor, and MRA. So the data is showing earlier we start, the more is the benefit on the patient mortality. So what I follow is I usually combine, like patient comes with heart failure, should combine AC inhibitors, mRNA, and the diuretic like furosemide, furosemide, or uh, the long acting diuretic like furosemide. So that the main concern is potassium level. So the MRA, they increase the potassium level. AC inhibitors, they increase the potassium level, whereas the diuretic like furosemide or furosemide, they reduce the potassium level. The importance is to keep the potassium level something around 4, between 3.5 to 5. Then initial the data was the real study, and the later on came. So what the incidence of the side effects like gynecomastia or loss of libido or menstrual irregularities, increased vaginal bleeding, they are more seen with aldosterone antagonist, and it was quite less seen with levodopa, and gradually the patient's side effect profile as it goes down with the epinephrine, so it is more preferred as compared to, however, cost wise is not much difference between both for the long term. So it depends on the practice, whether somebody is using spironolactone and patient is asymptomatic, we can continue using it. A patient develops side effect with it, then we can switch out epinephrine, or initially at the start only we can start using epinephrine alone or in combination with this spironolactone. So the importance of potassium is because many times these patients are also having renal dysfunction, and we need to be quite careful. Potassium level is more than 5.5, then we should not start with both ACE inhibitors and MRA. We should wait till potassium is less than 5, preferably less than 4.5, and we should use the half dose if there is a creat clearance less than 30, like creatinine more than 2 in females or 2.5 in males. So it is important to assess the kidney function level and potassium level. And if potassium level is more than 6, we need to stop MRA as well as inhibitor, reduces potassium after 1 week, give the potassium treatment to reduce the potassium level like K binders and uh, tosimide or sulfasamide, and then retake after 1 week, and then slowly introduce with low dose, half dose of ACE inhibitor, gradually then add on to MRA. So this was some study related to hyperkalemia, and studies, meta-analysis and randomized studies, the prevalence of hyperkalemia was 2 to 4%, but actually in practice we see the hyperkalemia in 5 to 10% of patients, and we need to be careful when to optimum like or ACE inhibitor to maximum doses, and in combination there are chances, but we should not fear about the hyperkalemia if we keep a good follow-up and monitor the potassium level. I think that will be the most beneficial for patients, because if we do fear for the hyperkalemia and don't start MRA, then patient will not get benefit. So any comment regarding how many percentage of hyperkalemia we are seeing in our practice? Any comment from expert panel?
Hello.
Yeah.
Yeah.
Yes,
Dr.
sir.
Lohiya, can I ask you something?
Yes, sir.
So what about the, I think, what is your experience regarding the level of potassium? Because 4 to 5.9 are above the 6. We have to start the MRA, number one. As well as we
Yes,
have
sir.
to see the renal function, that the estimated glomerular filtration rate is less than 30. So what is your experience? Because there is a very little bit, I think, changes inside the 4.59, 5 point, up to 5.9 or up to 6. So what is your experience? You have to stop immediately after the 5 or
Yes, sir.
after the 6?
Yes, sir. So if potassium level is on the lower side or less than 4.5, I start with both like aldactone and ACE inhibitor like ramipril or MRA, these ARBs. And then we repeat potassium after 3 days and 1 week. And if potassium is not going above 5, if potassium is less than 5, I'm comfortable to continue and optimize. If potassium is less than 4, so right and kidney function is normal, I do start with 50 mg of aldactone. And if patient's BP permits, then we start ramipril 5 mg, and and we follow, but we do follow patient after 5 to 7 days. And if whenever there is a potassium, that is a point we need to stop one. And if patient is also having volume overload, or if patient is not on tosimide and there is LV dysfunction, we do add low dose of tosimide so as to counterbalance the potassium level. But we some in a very rarely we see potassium going above 6, and that is we need to avoid. We have to have a good follow with the patient, because once in a while in a 6, potassium going above 6.5, patient coming with bradycardia and requiring TPR, that this we need to avoid with a good follow.
Okay, thank you, Dr. Lohiya. And second thing, what about the elderstand escape? Because after the discharge of the patient with MI, when you have to start this next run, then every patient shows that higher side of this.
Yes, sir.
You have to differentiate
As we see the patient having the maximum chunk of profile is having significant LV dysfunction, and we do discharge this patient with a low dose of diuretics like tosimide 10 mg per day, and they, along with that, what in my practice I follow, I give tosimide along with aldactone, like we have diper plus, or we have along with the combination of the eplerenone, or we have lacilactone. So any combination of the diuretic with aldosterone antagonist, and I don't see much hyperkalemia with this combination. And in follow-up, like the patient is on 50 mg aldactone, and like dipyrotonic patient is having 10 by 50, and in follow-up we adjust according to the symptoms of the patient, and we gradually up titrate AC inhibitors, and then we up titrate the MRA. At least what recommended is we should have 50 mg minimum to have benefit to the patient, and the chances of hyperkalemia is high in the patient who are having high creatinine, like more than 2.5. So these patients we need to be careful. And yeah.
And we will see also in the case of elderly. Actually, Dr. Lohiya, I'm a professor in
Yes, sir.
Allahabad Medical College.
Yes, sir.
Basically, I think doing the afterlook of elderly patient in geriatric medicine. That's why this is a very, you are telling 100% right, that it is very difficult to manage in a elderly patient.
Correct, sir. Correct, sir. We need to avoid these hyperkalemia, because once if potassium goes above 6.5, it is life threatening. Anytime patient can die. So we need to avoid that. That is very important.
Okay. Thank you, Dr. Lohiya. Thank you. Continue. Okay. Proceed.
Yes. So this was from FSR study which had shown when we start eplerenone within 1 week, the benefit is maximum. If we start after 1 week, then the benefit goes down, but still that depends on patient's clinical profile, renal function, and potassium level. But whenever possible and potassium is not high and kidney function is normal, we need to start at the within 5 days. So the therapeutic algorithm optimize over the long term. Like one month, we need to optimize ACE inhibitor or RNA, beta blocker, mRNA, and now we are having these SGLT2 inhibitors. Keeping in mind the side effect profile of this medication, and as most of the patients are having fluid retention who are admitted, so we give loop diuretic. The important is whenever patient is asymptomatic or patient is developing hypotension or patient is developing dehydration due to whatever the, whether loose motion or like in summer season. So if we stop the tosimide or furosemide and we just continue the MRA, we need to be careful regarding potassium level. And whenever we are upgrading the dose of the MRA or ACE inhibitors, we need to monitor the potassium level after 5 to 7 days. And we need to start all these diuretics, mRNA, MR antagonists, beta blockers, at least in NOIH class 2. And I think most of the combination of or spironolactone and tosimide in patients with CCM. But if patient is asymptomatic, no shortness of breath, good functional capacity with LV dysfunction, so 25 mg or 50 mg spironolactone or eplerenone to start with, minimum 50 dose, gradually increasing maybe over 2 weeks to 1 month, and then increase the doses as per the patient's condition, and at least 50 mg he should be on for maximum benefit. Apart from that, I think the patients of sometimes we do give this MRA to patients with hypertension quite less often, but sometimes if BP is like patient is on ACE inhibitors and there is a increase in the BP, then we can add on. Or patients having liver cirrhosis, where we are quite often using the aldactone. And I think some data is coming, so we need to have a good data in Indian setup. So there need to be a good initiative, and there should be a database in Indian patients. How many patients are given all these medication at optimum doses, and how many patients in Indian population we are seeing the side effects. And I think these data collection, the company fellows, they can help us and they can give incentives for doing studies, because government is not that much doing in these cases. But still, if we connect both government and private setup, and we can support these developing the data regarding Indian population. And one more thing what I would like to say is sometimes the patient is developing potassium on the higher side, like going above 5 up to 5.5. And we think we need to give MRA to patients along with the directives. We can add potassium binders and have a close follow-up. Yet the robust data is not available as per this, but we need to have a look at this point. So I think the forum is open for question, answer session, or any discussion among the panels. Any opinion among all the expert panel.
Hello, Dr. Lohiya. I am Arun Pandey.
Yes, sir.
What about the SGLT2 inhibitor in heart failure? Because invariably without diabetes or with diabetes. So what is your own experience regarding this? You have to use with the MRA as well as the other diuretics.
So we are using it and it may reduce the need for diuretic, but we need to be careful if patient is having UTI. I don't start it. If
Mycotic
patient is not
infection and
affording,
UTI. Yeah.
and if we need to see whether patient is affording also, the still cost is quite high. The first thing, maybe if patient is affording, we can start with the low dose inhibitors like, but these medicines which are quite cheap like aldosterone antagonist, aldactone, beta blocker, and ACE inhibitors, and the maximum 95% patients they are not affording for long term. This is the long term, and they leave the medication because of the cost. But otherwise, if patient is affording and tolerating, we can start with all ARNI and the AGLT2 inhibitors.
Okay, thank you, Dr. Lohiya. Okay.
No, any other question or any comment from any experts, sir? Any experience, sir, from your practice, sir? How many patients, Pandey, sir, how many patients who are using these ARNI or AGLT2 inhibitors?
In my medical age, early they have started, and it's not more than week. You can say that cath lab is there, and then regular OPD have started before today. It was associated with the medicine department. So now they have started it, but in my practice, what I have seen, that it was a very little bit. Basically, two reasons is there, that the expert like you people, they are using in a such a way from according to the NHI classification recommendation class 1A and class 1 and class 1 to A up to the 2B and the 3. It is never be seen in my practice, whatever I have seen here.
Yes, sir, yes. We can always avoid class 2B, but at least class 1 and 2A is can start.
Yes.
Thank you, sir.
Okay.
I think with the summarizing the things with data from the so many studies, landmark studies like RAILS and EFASERS and the other data from these, they are changing our guidelines from the ESC and ACCH in 2021. They are recommending these five pillars of the heart failure. ACE inhibitors or ARNI, MRA, and beta blockers and AGLT2 inhibitors. Even now in heart failure patients with ejection fraction, we need to see the effect of SGLT2 inhibitors, how much they are beneficial, and MRA antagonists. So we need to compile the data for these patients. I think with these comments, I can hand over this to. I also thank Siplati for organizing this giving the opportunity to have some talk regarding heart failure and the MR antagonist.
Thank you very much, sir, for your valuable time and efforts. The way you set the context of MRA as well as the diuretics and the useful of the heart failure. So again, I'm thanking to you and thanking to all participants and panelist members, those who are attending these events. And with this word, I would like to thanks to all and good night to all.
Sri Ram,
Thank you.
Sir Mahasankar here from
Ji.
Sipla.
Yeah.
Sir, for the closer this meeting, we required here, sir, video on all doctors actually, sir. Sir, we required, please put on your video so that we can take one snap at least. Please, sir.
So requesting to each panelist member, please put your camera on so that we can take the one photographs and we will close this, closer the events for head office level. I'm requesting to each one participants.
श्री राम, जितने लोगों का आ रहा है सर लेते जाइएगा, ठीक है?
हाँ. Yes, sir.
To have these academic initiatives, and I think now I don't think there will be a fourth COVID wave, so maybe there will be physical interaction at city level, each city, and then we can have the interaction at the state level.
Sure, sir. Sure. We will come with physical meeting also, sir.
And anyhow, the COVID has taught us to have a good discussion among the people sitting at any corner of the India and any country. So that will always be a good option to have discussion online.
Sir, Dr. M.K. Jaiswal, please एक बार और open कर लें camera. Yes.
Thank you, Dr. Lohiya. You have presented it very nicely, and each and everything is very clear. So I think in webinar, this type of meeting is very much beneficial for all those physicians also. Thank you so much. Thanks a lot.
Thank you.
Okay, sir. Thank you very much and good night to all participants and moderators, sir.